Joining us again for our second surgery of the day. Today we're going to be taking off with a DLDR, which is the Deuk laser disc repair, on the left approach at L45 in the lumbar spine. On the screen you can see the patient's MRI report. We use this report in our hopes of diagnosing properly. We also do a bunch of other diagnostic tests, including a discogram during the surgery to make sure that the levels we're at are correct. If you look on the screen at L45, this patient has disc desiccation, a disc herniation, arthropathy, and neuroforaminal encroachment at L45. These signs indicate that her back pain, along with her leg symptoms, which are nerve-related symptoms known as radiculopathy, are coinciding with this disc, L4, L5. That's what we're going to be operating at today. Now if you look on the screen, we have some keywords for you. Doctors often use these words during the surgery to describe certain conditions that need surgery to correct. You've probably heard these before if you have an MRI done of your spine. These are some common conditions that are located in the lower back. Stay tuned and we'll be going live in the OR with Dr. Deuk shortly. I would also like to take this time to let everyone know that we do free MRI reviews here. What you're seeing on the screen is a result of an MRI review. If you have copies of your images and your report on a CD, you can submit them on our website at mri.deukspine.com in order to get a free review done by the neurosurgeon here. We can help determine the best treatment options for you and answer any questions you have about neck or back pain.
Did Sean do a countdown?
Yes, sir.
Sean,
Yes, we are live.
okie dokie, everyone. Dr. Deuk Majin. It is August 18, 2020. We're here at the Deuk Spine Institute in Melbourne, Florida, broadcasting live to you over the internet through Facebook, Periscope, YouTube, so you can all watch live spine surgery. We've been doing these broadcasts for 7 years. Every single week, every single surgery we do. We broadcast for one purpose, education. We want to educate our viewers, whoever's watching, on topics related to the spine conditions, back pain, neck pain, curing back pain and neck pain, treatments, diagnostic workup, recovery, whatever it is related to the spine. And we do it during the surgery where we have questions and answers. So you, the viewers, can post questions. Our surgery today, we've already done a fusion of the lumbar spine. This next patient is having the laser surgery, the Deuk laser disc repair done. They have a herniated disc. It's been pinching the nerve on the left side for 11 years, causing pain down the left leg. It's getting worse, as herniated discs always do. They get worse over time. And this patient is tired of suffering and wants to get it fixed. She's got some back pain, but it's really mostly her left leg. All right, this is Dr. Deuk. I'm touching your back here, okay? She awake or sleepy? All right. So I'm going to numb up her back while she's sleeping. I'm going to give her some numbing medicine. She'll probably feel it anyway. And this is L45, correct? So I'm under the skin. I'm injecting. And this is probably one of the more uncomfortable parts of the surgery. The numbing medicine, believe it or not, going in hurts. Once it sets in, it's fine. But going in there, it's uncomfortable. So it's a subcutaneous injection. I injected 7 cc's. So now we're going to go target the L45 disc, okay? And this is where her herniation is. It's a foraminal herniation. It's right in the neuroforamen, right where the nerve comes out on the left side. That herniation is pushing on the nerve and also irritating it chemically with inflammation. So we're going to go in there and fix that. As I'm going in, I'm injecting a little bit more numbing medicine just to make it more comfortable for the patient. Now we're going to take some fluoro pictures. Nice job. Let's go with a lateral view, please. So we're going to use x-rays to navigate to where I need to be with this for this surgery. So remember, we have to create a pathway for me to operate. It's a straight pathway. It goes from the skin outside to the disc. All right, so it looks like we need to do some of this. Probably your side down. Let's see if that helps. It's hard to tell. Let's try a little more. See, the reason for that is she's rotated there. Yeah, I think that was a little bit overshot. So let's go back a smidgen, like 2 degrees, 1 or 2 degrees. That's pretty good. Let's just leave it there and see what we get, okay? All right, so are you comfortable? I kind of need her awake. She should be awake. All right, good. Shot? Shot? Let's go AP. We're aiming for a disc that we can see on the x-ray. It's the disc between the number 4 bone and the number 5 bone. And for those of you watching, you can see the needle coming in on the left side of your screen. Go back to a lateral. That needle is aiming for the bad disc. And you can see some bone spurs right there. Kind of like a beak, a bird's beak, reaching out to bite the needle. Nicely done. I want to target the facet, and there it is. I just targeted it. And then I want to go around it. Shot. Too low. She awake? Shot. Is she awake yet?
Kathy?
Shot. Hey, just lay still. Okay, why is she?
Kathy, you waking up?
Shot?
Kathy? Kathy,
All right. So
you waking up a little? Kat,
let me know when she's awake enough. Shot?
can you hear me?
Give me an AP view.
Kathy, can you hear me? Kathy? Kathy, can you hear me now? Swallow.
So we like to put our patients to sleep in the beginning because it makes it more comfortable. All right, back to a lateral. We're right where we need to be. I want to make sure she's fully awake.
Kathy, who's talk to you? You waking up? Yes?
Nice job, Dr. Arcos. Let me know when you think she's coherent.
Kathy? Kathy? How you doing, honey? You okay? Can you talk to me? Yeah?
Are you feeling any pain? Shot.
Do you have any pain?
Huh?
You feeling pain?
Shot. All right. In your back? Where do you have pain? All right. So we'll give her another minute to wake up. So to do these types of surgery, they're not percutaneous procedures. If they were percutaneous, we would just place the needle and then we'd put a laser fiber down the needle and I would just use the laser to zap some of the disc. That's a percutaneous discectomy, otherwise known as an IDET, intradiscal electrothermoplasty. IDETs don't really work, so that's why we don't do them. This is a true spine surgery, but we use a needle and a guide wire to get to the spine through a safe pathway. And that's really what the beginning of the surgery is all about, getting from the outside world where all of our instruments and treatments are down to the disc herniation. And I just put that needle through the foramen through her disc herniation, and it went in very easily. It went in easily because there's a massive tear in the annulus. Normally the needle would hit the annulus, which is the outer wall of the disc, and it would be very firm and hard, and it'd be hard to push through. But this thing went in easy because there's a giant tear, and that's what we're here to fix, is that tear. The Deuk laser disc repair is a repair of the tear of the annulus. It's the only surgery in the world that repairs the tear, and that's through a process called debridement. Are you awake? All right. Do you know who I am? Who am I? Good girl. Are you having any pain at all? All right, were we ready with everything? So we're ready. Let me just show you while we give her another minute to wake up. This is the endoscope. Okay, this is the endoscope. And there's a camera attached to the back. This is the camera right here. So just so you can all see, this is the camera in my hand right here. And my left hand is the endoscope, okay? This is what you basically buy, the endoscope. And it's around $11,000 or $12,000 now for these things. They're very expensive. This is the light source right here. So go ahead and turn the light source on so our viewers can see. And here it comes. There it is, the light source. You all see that? And that connects to the scope. And it transmits light down to the end right over here. So you can see the light. See that, Sean? Huh?
Yes, we do.
This is irrigation. It's basically fluid. When I open it, it lets the fluid come out. I guess it's still closed. Is our irrigation open? It's not flowing. It's coming. Alrighty then. So watch, there it is. You see the irrigation? So we've got irrigation, we've got light, we've got a camera connected to the back end of the scope so we can look at the image through the scope, project it onto a screen digitally. And this allows me to do surgery, right? And now we have a port. Let me have the grabber. Are you awake? Now when I put everything into its... Go Packers. Green Bay Packers, right? All right, so now notice I'm going to put my instrument in this end and watch what happens. I'm no magician, but watch the other end. Voila. There it is. Amazing technology. Okay. Okay. Are you comfortable? Good. How bad is that on a scale of 1 to 10? How bad? She said, oh shit, that hurts. Give me a number. 10. Is that where you typically get your back pain? Oh shit, yeah. Okay. So 10 out of 10 pain at L4-5. Folks, that's called concordant pain. You should be doing an AP if you haven't done it already. Now you saw all that dye leaked out through a tear in the back, and then that's why there's like a, it looks like a bow and arrow kind of bow right there on the spine on that lateral view. Look at all that dye leaking around the nerve root there on on the left side. So that's where the tear is, and we injected the dye in the center of the disc. It leaked out through the tear where the herniation is. That's what we're going to go fix. You can go nighty-night. When you wake up, we'll be done and your leg pain will be cured. You're welcome. I love you too. Shot. Give it to me good. All right. So we got our guide wire in, and I'm going to take the needle out. Shot. But I want to make sure I don't take the guide wire out with the needle, because that would be a big mistake. Then we wouldn't know where we're going. We wouldn't be safe anymore. If you ever lose control of the guide wire and it comes out, you have to start over again with the needle. Don't just blindly stick it back in. This is the Deuk laser disc repair surgery, the surgery that I pioneered and developed. Some of the steps you're seeing are standard endoscopic transforaminal steps that I learned, but what sets this surgery apart is what I do once I get into the disc with the laser, and it's a debridement. That's what I'm doing. Endoscopic debridement of the annular tear, and that's unique to my surgery. That's what I pioneered in the world. Published it back in 2012, the first person in the world to do it, and it has been curing back pain and neck pain as a result of that procedure. All right, you can see the dilator is now in the foramen. It's right at the back of the herniation. You see how the herniation bows backwards towards the tip of the dilator. We're going to go in through that tear. Okay, but I want her to be a little more asleep before I do that, because this is going to be the more painful part. Now, she told me her back pain wasn't that big of a deal. That's because she's been modifying her lifestyle to avoid irritating the back pain. She's been just kind of taking it easy. I need about 10 more seconds. Shot. I know, I'm sorry. We're done with the guide wire. I can advance the dilator into the tear, and now we're done advancing. We're going to do the whole surgery through this tube, folks. You see this? I know it looks like a shake straw. Speaking of shakes, it's so hard to find a good chocolate shake anywhere these days. Everyone uses vanilla ice cream and they just put chocolate syrup. It's just terrible. We finally found a place that uses chocolate ice cream. What a difference it makes. My son won't even drink a fake chocolate shake. It's a pain in the butt because I got to take him everywhere in town to find a place that makes real chocolate shakes. He's very particular. I think I am too, but not quite as particular as he is. All right, we're done. We got the tube in, shot, perfect, get the fluoro out. Now that tube going in is going in through the tear that I was telling you about. And it's the annular tear that is the beginning of a disc herniation. All disc herniations start with an annular tear, a tear through the annulus, from the middle, from the center of the annulus or the inside wall through the outside wall, through about 25 layers of collagen. 25 layers of collagen. That's what makes up the annulus fibrosus. Collagen is basically connective tissue. Alrighty, here we are. We've got everything hooked up. Can you all see this, Sean?
Yes, we can.
A little bit of herniated disc there. Hey, you all see that? We've lost like 3 drops of blood, 1 milliliter. And here goes the endoscope in. My wrist needs a wrap. My wrist needs a wrap. Into the disc, down the rabbit hole. It's a little bit like Alice in Wonderland. There's the annular tear. Right there, you see it? The white on the right, the white on the left. and the blue in the middle, that blue is where the tear is. I'm going to get the laser going, and we're going to debride the tear. Again, this technique was developed by Dr. Deuk, that's me, and I published it in the National Library of Medicine in a journal called Surgical Neurology International. That was 2012, so we're talking 8 years ago it was published. And it was one of the most important publications I ever had in my career because it set the stage for these types of treatments to become more mainstream, which is what needs to happen. If everyone knew how to do this surgery, there'd be no need for fusion surgery. Fusion surgery could be basically removed. Probably 99% of fusion surgeries will not be necessary because doctors could be repairing the disc rather than removing the disc and fusing. So right here, this is all herniation. Look at that right there, the blue stuff. And it's jiggling around and jiggling out. There's a piece of herniation. I like to try to grab the chunks of herniated disc with a grabber. Sometimes it works, sometimes it doesn't. But typically I need to do a combination of the laser plus the grabber. You need both. The grabber has a name, it's called a pituitary rongeur. Rongeur, anyone know what the origin of that word is? What language? French. Oh, there's a piece of herniation right there. French, of course. Rongeur is French. Most medical terms are based in Latin. Rongeur is a French word. Most of the conditions of the human body that are abnormal were named by a group of doctors called pathologists. And pathologists for hundreds of years, since the 1600s, were probably the most important types of doctors because they were describing the diseases that were occurring in human beings, right? They would take the organs out and they would look at them and study them and try to figure out how they were a deviation from what's normal, right? So cirrhosis, liver disease, for example. The pathologist studied it in people who died from cirrhosis, and they noticed that their livers were not the same as normal people's livers that didn't die, people that died of natural death. And then they discovered that a cirrhotic liver, and they started to find the differences between normal and cirrhotic. And those differences is called pathology. It's a deviation from normal. Abnormal is what pathology really is, a study of abnormal physiology, abnormal structure. So basically abnormal structure and function. Pathology started with the study of organs, gross organs. Gross means just full organs like a liver, a kidney, testicles, whatever that was abnormal, prostate, brains. And then eventually as microscopic techniques became abundant, using the microscope to study tissues, specifically to study the cellular structure of tissues, pathologists started to describe abnormalities at a cellular level, the organization of cells into tissues, structures, nests of cells. And they found that certain diseases had a certain histopathological characteristics that were seen with the microscope. And then stains were developed, staining the tissue with different types of stains. And they found that certain types of diseases had a certain appearance with specific stains. Okay? And so for hundreds of years, pathologists, they're known as the teachers of doctors, because without the pathologists, we would never understand anything about the human body and the diseases that affect us. We would be still in the dark ages of medicine. I'm not a pathologist. I'm a neurosurgeon. But the value of pathology in medicine was taught to me in medical school by pathologists, some of the best in the world. I was fortunate enough to study at USC in Los Angeles, where Clive Taylor and Dr. Chandrasoma, two of the most prestigious and well-renowned pathologists in the world, where they actually taught at USC in Los Angeles. If you want to be a doctor someday and you're interested in learning medicine, my advice to you is to go to the best medical school you can go to and study your books every day. Dedicate yourself and commit yourself to learning about pathology, histology, anatomy, biochemistry, cellular biology, all the disciplines that are important to understanding the basis of disease. And then you can become a great healer someday. But there's a fundamental understanding of pathology that allows doctors to be successful. Why is this catching? You guys got to prevent that. That allows doctors to become successful at curing disease. But you have to understand the basis of disease to cure it. It's like you have to understand your enemy before you can defeat them. Disease is the enemy. You want to defeat disease, you have to understand it. All right, so we're using the laser, which is the blue fiber, to remodel or debride the annulus, the annular tear specifically. And a lot of this is scar tissue right here. Scar tissue is from the annular tear. The annular tear itself was the original injury. Once the annulus tore, the jelly from the center squeezed out, and when it squeezed out and started interacting with the blood vessels or capillaries within the annulus, the torn annulus, it created inflammation, and that inflammation is what causes the pain. So it's the annular tear that gives rise to the herniation or allows the herniation to occur of the nucleus pulposus, which is in the center of the disc, and then it is the herniated nucleus which elicits an inflammatory response within the annulus, and it is the inflammatory response within the annulus that creates pain in the back or neck, or thoracic spine if it's in the thoracic. So the first step is always the annular tear. Believe it or not, many doctors don't even understand that. It's shameful. Do pain management doctors know that, Dr. Arcos? They do, right? I mean, it's amazing. I read a paper the other day where they were talking about the basis of disc herniation being the avulsion of the annulus off of the end plate. Yeah, but it's not the end plate. That's the whole point. It's the annular tear. It's basically the center of the annular tear. It has nothing to do with the end plate. Yeah, well, it's definitely an inflammatory thing, but I think pain management doctors understand that better than surgeons do. Surgeons are in the dark for some reason, but surgeons are the ones who can fix this. Yeah, I was with Dr. Eniken. Yeah. Yeah. We had great neuropathologist Tony Yaknis was there as well, who studied under Dr. Eniken. There's a piece of herniation right there. That's a good one. So one of the nice things about this procedure is I actually push the herniated fragments back into the disc as I introduce the dilator through the annular tear. All right, we're making good progress. We're going to pull back a little bit, see some more of this tear. And then look at that inflammatory tissue, guys. You see it? It's at 1 o'clock. That pink stuff, it's called granulation tissue. And granulation tissue is inflammatory tissue. Remember, the blue stuff is the nuclear material. It's all stained blue with the dye that I put in to help me visualize it better. Question, Sean?
None currently.
All right. While you're watching, we'll tell you Deuk Spine Institute is who's broadcasting the surgery live. This is an outpatient spine surgery you're watching. Our patient will go home today. And if you want to avoid a spinal fusion, that should not be pulling on me, you should consider this surgery, the Deuk laser disc repair. It's the alternative to spinal fusion. If you've been recommended for a spinal fusion, get a second opinion with Deuk Spine Institute. We do free second opinions. We do free first opinions too. All can be done through telemedicine over the internet. You just have to send us your MRI, a copy of your MRI digitally. You don't even have to ship it to us. Just send us a copy of the MRI digitally and we will review it and see if you're a candidate for this incredible surgery to avoid having to have a fusion and avoid having to live with pain. Even if you haven't been told you need a fusion, if you're living with chronic back or neck pain, contact us. We can help you. So the blue fiber is the laser, and I'm just gradually removing and debriding the annular tear, removing all this tissue in here that shouldn't be there, that's wedged in there. Mostly it's nucleus pulposus. Some of it's inflammatory tissue like scar tissue, but it's a combination of nuclear material and inflammatory tissue and just shredded annulus fibrosis. All right, we've got about, I would say, 5 more minutes, doctor, and we'll be done. This is again the tear. You see the blue. The blue is the tear. It's the center of the tear. All this whitish stuff is scar tissue within the disc from inflammation. That's how the scar tissue gets there, folks. Inflammation. And it's the inflammation that causes the back pain and the leg pain. And there's the end of the disc right there. That reddish material to the right, that's the end plate, by the way, of L5. That's the superior end plate of L5. We're right at the back of the disc where the herniation is. That's the end plate that's bleeding a little bit. This is posterior longitudinal ligament and a little bit of herniation that's through the ligament into the epidural space, posteriorly, right there. You can see all that stuff squeezing out like cheese. Fromage, c'est fromage, it's cheese. So I started telling you about pathologists and their role in the advancement of medicine, medical sciences, and disease, the understanding of disease, and ultimately the treating of diseases and curing of diseases. Very important. But pathologists back in the day, hundreds of years ago, back in the 1600s, 1700s, 1800s, they would sit around all day looking at these diseased body parts, and they would eat their cheese and they would drink their wine while they're sitting there with a microscope studying these tissues. And they would, when they were hungry and they encountered a new condition, they would name that new condition after one of the foods that they like. So a lot of the diseases that we have in medicine that are named by pathologists, which is most of them, are usually they have names of foods that they're named after. Because pathologists just love food so much. They love to sit around in their little dark rooms staring at body parts and eating cheese and drinking wine and eating bread. That's all I'll say about that. Was eating fish? Trichomonas? Is that right? I don't know. Oh, the fishy smell? Trichomonas vaginalis? No, I think that's just the smell. Yeah, it's pretty bad. That's why we don't do that gynecology here. Yeah. But you're right. They probably love fish. All right, look at the top there. There's a little bit of fat with some veins. That's in the epidural space. Again, the white stuff here is the back of the annulus where the herniation is, the back of the herniation. Everything above where that fat is, that's where the nerve's going to be. So we don't want to get up in that area. There's a bone spur. I want to look a little bit north. Okay, you're going to see a nerve root up here soon. We don't want to do anything bad to the nerve root. But I do want to get all the herniation out that I can get out laterally here. If we were doing open surgery, this part of removing the herniation is what we would do with open surgery. What we don't do with open surgery is we don't do a debridement. The annulus never gets debrided because you can't see the annular tear with your own eyes when you're doing open surgery. It's too small. The only reason we're seeing it now is because we have an endoscope. We're looking endoscopically. That's all just fat. And let's take a look at the nerve. All right, hold this. You ready? We're going to see the nerve. It's right up in here. It's in that fat right there. All right, I wonder if we can get a little piece of that disc right there. Let's see the laser. So the nerve is covered with fat. So we're not seeing a good clear picture of it. And I want to make sure I get as much of this lateral herniation as I can. Got another minute left. We'll be done. That's one of the mistakes that new surgeons just starting to do endoscopic surgery, they don't understand there's a lateral component to the herniation. So this is a little bit here. Sorry, Louise. Just want to make sure we get all this. Got to be able to rotate it. And why am I having trouble with the pedal? Is the pedal turned wrong?
Still the same.
All right. That should be, I need a little more on the wire. Yeah, right there is perfect. Yeah. All done. All right, laser off. And looking good. Looking good. Let me get just a little bit more here. Right there. I may want to take a grab too. Sorry. Yeah, just let me get a quick zap over here. Make sure there's nothing substantial being left. A little bit there of the herniation.
Kathy, waking up now? About done.
Yep.
Yeah, just about done.
Yeah, just about done.
Okay.
Just putting in the last few touches.
Couple of deep breaths now.
Grab her. You did great. Laser. How's our irrigation? Good? Okay. No, I'm done. Yeah. I'm sure. Scope off. Unless you want me to keep going. We're done. You did good. Everything went perfect. Couldn't have gone better. You did really good. Pressure. All right, let's show the audience where we did the surgery. Okay, you ready, Sean?
Yes, we can see.
All right, right here. 7 millimeters, the whole surgery was done. Compare that to the last surgery we did. Thank you. Oh, watch that. All right, any questions from our audience?
We do not have any.
If you have questions, start typing them now and I'll answer them when I get back to the conference room. We're going to close up. No complications. Estimated blood loss 1 mil. This is a left L45 DLDR. I'll need that sheet and the other ones. Good work, everyone.
Come on. I really feel great. I mean, well, before the operation, I could only walk up maybe 100 feet. I had to go back in the house. Now I can walk pretty much 2 miles every morning. In fact, they marvel at me at the gym that I'm able to do what I can do there. I'm kind of an inspiration for a lot of people at the gym.
My name is Greg Spadaro. This is my father, Jack Spadaro. We are from Connecticut. We moved down here. For me, it's been about 20 years. I think my father's been down here a good 24 years now. And we've been two individuals that have kind of suffered with back pain and problems for a good portion of our lives.
My situation started back in 1964. I had an injury bowling, and it was not a serious injury, but someone at the time recommended me going to a chiropractor at that time. And I went to this guy, and I went to see him, and he ended up rupturing my disc. It was the first operation. It was a neurosurgeon in Hartford, Connecticut, named Dr. Scoville. And he did an excellent job, and for years after that I was fine, until I got here in Florida again, and my back problems started again. But we went up to Tampa. I had several laser surgeries done, which actually only aggravated my situation. And then locally we had a neurosurgeon here that became well respected as an excellent surgeon, and he operated on me twice. And my situation only got worse. I was bent over with the pain in my left side for a long time, almost 2 years. And then I heard my son telling me about Dr. Deuk. And so I ended up going up to see Dr. Deuk and explained my situation to him, how I was in such pain and such, and he took an x-ray and evaluated me, and he showed me on the x-ray how my operation actually had come apart. The fusion that they did locally here had come apart, and the nerve was being impinged on by the bone. So he recommended to me that we needed to be operated on, and he told me what he was going to do and how he was going to do it, and that he felt he can help me. He was so convincing, and I was so desperate at that point because of the pain I was in, that I ended up going ahead and we did the operation. He did L2 to S1.
So 4 levels.
And it was a major operation. And thank God, thank Dr. Deuk that he gave me my lifestyle back again, because from the moment after we came out of the recovery room, I was able to stand straight. I told even that time, even though I was still under anesthesia, I said I could feel I'm standing straight with no pain. He even made me dance a little bit at that point in time, you know, which was kind of funny, you know. But I've never taken any pain pills. I mean, it's amazing with the kind of pain that I had originally, that after the operation it was totally gone. And so from my standpoint, my lifestyle is back. I stand straight, I have no pain, I go to the gym twice a week, I walk every day, and there's very few things that I can't do at this point in time, especially at 80 years old. I'm very proud to say that. I couldn't stand and hold him like this before the operation. Come on. I really feel great. I mean, well, before the operation, I could only walk up maybe 100 feet. I had to go back in the house. Now I can walk pretty much 2 miles every morning. In fact, they marvel at me at the gym that I'm able to do what I can do there. I'm kind of an inspiration for a lot of people at the gym. I still do all the maintenance of the house myself. I do the lawn, fertilize, I trim the bushes, I do the pool, I do pretty much everything. The fact that I can do this now is unbelievable. I couldn't walk, I couldn't lift a finger until I had the operation. It's easy to recommend Dr. Deuk and his staff up there because they're professional in every sense of the word. My operation, as I say, it was a big operation. And as far as pain medicine, I didn't have to take any pain medicine after the operation, which was significant because I'm allergic to pain medicine, which causes other problems for me. So I would recommend Dr. Deuk and his staff without reservation.
Okay, Dr. Deuk here, and I was just checking on our patients that we operated on, the lumbar fusion from earlier this morning. She's ready to go home. And I'm going to go see if she wants to do a live stream video in a few minutes, and we'll just go ahead and live stream her from recovery. So just to remind you, she was a patient who had had 2 back surgeries. I talked to her in recovery a few minutes ago. She said she had 2 back surgeries done. They were done at the Bonatti Institute. They did not work for her. She had instability of the spine as a result of those surgeries being done. They removed bone. They created a lot of scar tissue. There was a spinal fluid leak, which was never mentioned to her. She told me that nobody told her she had a spinal fluid leak. Again, we're not talking about this patient. You just watched the surgery. We're talking about the first surgery of the day, which is a different patient. Anyway, we're going to do her interview in a few minutes. The patient we just finished, she was an L4-5 Deuk laser disc repair, left side approach. She had left leg pain for 11 years as a result of the herniated disc pushing on the nerve and irritating the nerve. We went in and we zapped away the herniation with the laser. We cleaned up the annular tear. Her back pain is going to be gone. Her leg pain is going to be gone. She's in recovery, doing well. There's no question, so we'll sign off and we'll be back shortly with our last laser surgery of the day.